The human body is a fragile thing and we'll all experience pain throughout our lives. Sometimes it'll be mild and sometimes severe. And in order to get the right treatment for the type of pain you have, you need to be able to communicate to your doctor exactly what type of pain it is and what level of pain you're in. I asked pain expert Professor Michael Cousins about the challenges of communicating pain.
Pain is not a sensation, it's an experience, and it's described as a sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So as you can hear there's quite a wide range of factors that could be involved in an individual patient's pain. If there's no method of evaluating the pain it's not really objective because the pain is subjective, but it's a documentation of the patient's experience, then how are you going to know whether they're getting better from their pain or not? When you evaluate the pain, you're going to be looking for factors in three areas. So they'll be physical, psychological, and environmental. And they all contribute to every person's pain to some extent, and we have to weigh up the potential contribution. It's been a neglected area. It's a lot more complicated taking a pain history than many people think. There are a lot of ingredients involved, but that rapport just has to be there. That will determine, for example, whether you say, well, at the moment we need to give this patient some opiate drugs. Their pain is so severe, we've got to get it down. It'll help us to evaluate things further. So that's in an extreme case. There's a lot of physical component to that pain, but also there'll be psychological and environmental factors. Another patient, there might be such an expression of psychological and environmental factors operating that you're not going to use opiate drugs or any drugs, as a matter of fact. You're going to do a lot of things in the self-help area and teaching non-medication methods of pain control. Don't rely only on medications.
So what are some of the tools that patients can use to communicate pain effectively?
Well, there are a number of very simple tools, and a pain scale is a good starting point. So the visual analogue scale is one. Now, Sean, I want to ask you quite a key question, and that is about the severity of the pain. And I want you to imagine a 10 centimetre line. So the end of the line opposite where the 10 would be, we'll mark that as being the most severe pain you can possibly imagine. Mm-hmm. And then the 0 level will be no pain, obviously. Okay. So when you're at rest, yep. Most of the time, on average, what level of pain out of 10 have you been experiencing?
I'd probably put it at about 3 on a good day. Mm. Yep.
And what about the maximum levels that you've been having?
It's probably gone up to about maybe 7 or an 8.
7 or an 8. Yep. And what percentage of the 24-hour day would it be up around that 7 or 8 level?
Maybe say 3 to 4 hours, maybe.
So that's quite a lot.
What happens if people get the communication of pain wrong?
Well, sometimes they get angry that they haven't been listened to, or particularly that they're being stigmatised. And one of the biggest issues in the management of chronic pain is stigmatisation. It also occurs incidentally with chronic cancer pain. So some people think, well, everything's fine with cancer because they'll always be believed, but that's not entirely so. So stigmatisation is an issue, and if a patient feels that they're not being believed, valued, and the doctor's talking down to them because he feels that their problem is trivial or not real, that really causes a terribly bad communication.
And it must lead to either too much treatment or under-treatment?
It will almost invariably lead to under-treatment, and for some patients they remember that interview and the examination that goes with it, which is usually not particularly kindly, for a long time. Well, the consequences are enormous. Chronic pain is really like going down a spiral of loss of all life activities, and I do mean all life activities. So they start to become depressed, sometimes anxious, particularly if they feel that there's a sinister cause for the pain that hasn't been found. They become irritable because the pain is with them usually all day and all night, and often they lose sleep. Sleep deprivation has a whole range of other effects too, which are pretty well known now. At first, their work effectiveness becomes reduced, and then progressively they're off work and then completely off work. There are financial implications. They often lose their job. They've often got mortgages that they can't pay. Then there start to be interaction problems with their family. They become irritable with family members. Even family members may not believe that the individual has a real problem.
And what clinical issues are there with over-treatment? What's likely to happen to the patient other than addiction? I guess addiction is the one that everyone worries about.
The usual over-treatment is the use of medications that are not really helpful and the continued use of them. So yes, patients become tolerant if the opiate drugs are used, and there are other drugs that are associated with tolerance. The dose of drug required to produce any effect becomes larger and larger. Usually the patients aren't addicted. If you can do something to relieve their pain, they won't continue to take opiate drugs. It's a matter really of dose escalation, physical dependence, so they will suffer withdrawal if you suddenly stop the medication, but that's a physiologic effect. The main problem is that for many patients with chronic pain, opiate drugs by themselves are not really a good solution.
For people at home dosing themselves up on over-the-counter medications, does that issue of tolerance arise there?
Oh, it certainly does, and particularly with drugs such as Panadine Forte, which is still right up the top of the popularity poll in medications taken for all forms of pain. So the codeine in Panadine Forte is metabolised to morphine, but they tend to take a lot of paracetamol too, because as the dose of codeine goes up, they inevitably must take more paracetamol, and that can damage the liver. So the simple message is yes, medications have a role in chronic pain, and fortunately we have some quite good ones now. The long actors are better than the short actors because there's a lesser tendency to tolerance with a long actor. But really other things have to be used in addition to medications, and very often instead of medications. And that's one of the big messages of chronic pain. Don't rely only on medications.